We'll be recording this. Thank you all for coming. Thank you, panelists. We're very excited to have you here. The panel was a request by you, the WHI Planning Group. A number of people have asked for updates about the other community-wide activities going on because some people think, doesn't the WHI do this, or who does that, or what's the goal of everybody's project, and there's too many acronyms for us to all know any of them entirely. So we have a few folks up here who will be speaking on a number of the projects going on in our community. If you could come take your seats, please. I'll do a very brief introduction, and then they'll be able to introduce themselves longer. But the point of this is really for you to get your questions answered. So you've gotten materials ahead of time, and the materials are not going to be, we're not going to go through the materials individually on the panel, but if you do have specific questions, please write them down and think about them, because the last half an hour of the meeting will be questions that you can ask the panelists. Jack Billy's going to start us off. He works at the University of Michigan Health System, and he's also very instrumental in a number of the projects going on, so he'll frame the conversation. And Diane, as she said earlier, she works with the Michigan Primary Care Demonstration Project, and that's a statewide demonstration. There are some practices here in Washtenaw County. Tim Peterson, he works at the university as well, and he is with their new population health office, which has fingers in a lot of these projects as well. And then Jenny works at the VA talking about a lot of their integrated care. So the integrated care that they have is a really great model for some of the things we really want to do in the Washtenaw Health Initiative. So we really can learn a lot from them. And then Lori will finish off the panel by talking a little bit about how is everybody's information system working together, because the big thing about this is collaboration, and it's, or what goals we might have in the future of working together. So I will be moderating, and please, if you can possibly do so, take 5 to 7 minutes, and we do have a mic. But I don't know, we don't need it, do we? Can you hear it?
Yeah. Wave if you can't hear.
Okay. It's ready to go.
Good, thanks. So I'm Jack Billy from the University of Michigan, and first I want to do a couple of call-outs to some critical people. First of all, Bill Folletti from Integrated Health Associates, because they've been a partner in a lot of the things that we're going to talk about today, and you'll hear them mentioned. And also to Tom Simmer, Chief Medical Officer from Blue Cross Blue Shield, who's been an architect of population health across the state and an advocate for the really sane, logical, humane, and compassionate transformation of care in this state. So a lot of this would not be possible without Tom's guidance and support all along. He's been a great colleague in this, and we're lucky that he's able to be here today. So the quick history of population health at the University of Michigan, I knew that would happen, that was the last time we'll hear that. Population health within Washtenaw County is none, some, many, too much. And so that's what's happened here. Population health just means understanding a group of patients or people in a community and what their healthcare needs are, and then trying to meet those needs in a sustainable fashion. So that's second nature to everybody in this room, because you might be saying, well, what have we been doing here for the last year? It's nothing but population health. But when we use that term, we're generally talking about it from a physicians or health systems perspective. So we're often talking about an insured population and meeting what's called the triple aim, which is for this group of people, like all my patients who have Medicare, which Tim will be talking about, for this group of people, can I make sure that we provide optimal health of that population, that we do it at the lowest possible cost, and that we provide an excellent patient experience so that they don't have to go through fire and brimstone to get the health that's improved. So it's fairly simple, just 3 things for a particular population. Part of the reason I wanted to, I'm really encouraged about this panel being here, is the way I look at it, there's a kind of an umbrella for the people who have health insurance and or are served by the VA, and they're essentially being represented by the people on the table here. And then there's a whole bunch of people who aren't really well served by the existing health insurance market and provider community, and that's what WHI is all about. And part of my vision when we were talking last meeting about where should we go from here is to try and glue those two semicircles together so that we can make this a true community-wide approach. The payer-oriented, that is insurance company-driven transformation that we'll be talking about, combined with the community transformation for underserved people who are uninsured or who have community health plans, Medicaid and the like, who often have access difficulties. So actually this county had a great kickoff for population health because the two health systems through MCare and Care Choices actually began doing through HMOs was an early version of population health, trying to understand a population, meet their needs, making sure people got medical homes and that those folks knew about their patients and tried to improve them. But through a series of experiments over the last 10 years or so, which will be commented on by my colleagues, we have expanded this so that there was a Medicare program Tim Peterson will be talking about, a program for Medicare, Medicaid, Blue Cross and Blue Care Network patients that Diane will be talking about, and the latest variant on that called the Organized System of Care that Blue Cross has stimulated for their patients. And so at that point I said, and this is the title of what I'm supposed to talk about, enough already. We can't keep doing this piecemeal for this population. Like, I really want to know the color of the card in your wallet so I can figure out if I can send a social worker to your house or if instead I have to go through this pre-cert for this particular medication, or I'll be getting the data from this subset of my population different from that. So that's why, from my perspective, what I think we need to do is move to what I call an all-payer, all-patient perspective, which means that for the entire population, we have one model of care in this county, and it doesn't matter whether it's someone who's newly joined because of Medicaid eligibility, or they're in the Washtenaw health plan, or they're uninsured, or they have Blue Cross or Medicare or Blue Care Network, that we don't have to look at those features, but rather from the provider side, we're able to take responsibility for the people that have chosen us for their care, and as a result of that, we then provide the services that we think will be able to meet their needs. So this is a goal. We're not there yet, but you'll hear about the different experiments that are happening, and hopefully by the end of that, you'll see how these could be integrated together well. So I think we'll next turn it over to Diane, who'll talk about one of our most exciting new demonstration projects in the federal government.
Hi, I'm Diane Beagle-Marriott, and I'm so pleased to be here to speak just a little bit about the Michigan Primary Care Transformation Project. I am going to spend 30 seconds of my 5 minutes with a, I can't resist. I need to recognize Mary Ann Newdow, Dr. Tom Simmer, the saint of population health,
right? Indeed.
And Dr. Billy,
the devil of population,
who exactly, who is also in the canonization process. Without those three individuals, without Mary Ann, without Tom, and without Jack, the exciting work that Michigan is doing as a state, considering what we've been through in the state in the last 10 years, economically and from so many other perspectives, what a celebration that we in Michigan are the largest patient-centered medical home project in the nation. Michigan is doing tremendously exciting work inside the Michigan Primary Care Transformation and in so many projects outside of it. What a time to celebrate together. And I'll spend the rest of the 4 minutes and 30 seconds doing a short 10,000-foot view of the Michigan Primary Care Transformation Project, lovingly known as MyPICT. I know we needed one more acronym in the work together. At any rate, I also want to recognize so many in the audience who we've worked with and with whose partnership we have the pleasure to work. The Michigan Consumers for Healthcare and Steve Hernandez has been absolutely fabulous. So many others in this room. Lori, Tim, Mary Durfee, Jennifer are part of the physician organizations who are making this work possible. In short, the Michigan Primary Care Transformation effort is aimed at doing some specific things, putting trained care managers within primary care practices to use what we know in the literature will demonstrate that business case to the business community. And I come from the employer community. I spent 15 years on that side and know that this is the window of opportunity to make things happen. So we're all about how can we use the best of what's been shown to be effective from a cost perspective, from a patient-centeredness perspective, and from a quality perspective to enable the right things to happen in primary care and in the system overall. The effort places trained care managers within primary care practices that are of the practice and the physician organization's own choosing, and that meet with the patient face-to-face, eye-to-eye. This effort additionally has the range and the breadth of almost 1 million patients in the state, about 1,500 primary care providers, and 35 physician organizations. We could not be more excited. We are 1 year into our project. We have 2 more to go to achieve the triple aim that Jack was talking about. What we're trying to do, in short, is to make care management and care coordination something that we pay for in primary care as a model of how we pay, not as another special thing to do because it's the right thing to do. We want to make it the right thing to do and demonstrate that it's the smart thing to do. We also want to recognize that the care managers and the practices that are affiliated with our program it's a continual effort to build better coordination and co-partnership with so many other organizations in this room and outside the room who are part of the medical neighborhood. That's an effort that takes place and that we all get better at over time. We've made some inroads in that regard and think that there's more to achieve. But in short, I just want to thank everyone who's here because the work that you're doing is spectacular and it really enables us to move farther ahead as a state. And we're excited about the remaining 2 years and what can be accomplished, a success for the state, really an effort to serve all.
Diane, why don't you say who the payers are?
The payers are, proud of our payers and so grateful to our payers. Medicare, so the Medicare fee-for-service program, Medicaid managed care, the state is participating on behalf of the Medicaid managed care program, and proudly Blue Cross and Blue Shield of Michigan and Blue Care Network. We are on a continual path and are making some progress and want to make more in getting all payers in the state at the table. But those 4 payers stepped forward and were committed to the cause and have enabled our work.
Okay. Sir?
This is
Tim, this is just the microphone so that later we can webcast it.
so I can be held to everything that I say. Darn it. All right, well, my name's Tim Peterson. I'm the medical director for the population health program at the University of Michigan. That office has existed for about 18 months, actually. You know better than I would, to tell you the truth. I'm here to speak about the ACO project in specific. Just as a bit of background, the population health office at the University of Michigan is really the coordinating center for all of the shared savings programs that are sort of represented here. And so I do kind of have my fingers in all of these various projects from the university's standpoint. The ACO project is a Medicare project specifically. The population, and we were given a couple of things that I'm supposed to touch on, and so forgive me as I look down at my notes, but the population that we serve is really the attributed patient population for the groups that are involved, and that's really a program consisting of us at the University of Michigan, IHA, and 2 practices affiliated with the Huron Valley Physician Association. It's the Deb Peary practice and the Packard Health Clinic as well. In the first year of the program, which was the year 2012, it was just the University of Michigan and IHA, and then the Peary practice and the Packard practice are added this year. So this year we'll have about 2,600 Medicare patients. They're prospectively attributed to us, and we're responsible for the quality of their care. Excuse me, 26,000. I said 100, didn't I? Yeah, sorry, 26,000. We're responsible for the quality of their care as measured on 33 benchmarks that are roughly similar to the MyPIC benchmarks that are used as well. And then we're also responsible for the costs of their care measured against a benchmark patient population that's not really risk adjusted or anything particularly complicated, just a benchmark population that Medicare compares us to. The program itself is it's initially a 3-year program. The Pioneer program is a subset of all of the Medicare shared savings programs. It's unique in its risk model, and the details don't particularly matter per se. But the program itself started in 2012, so we've completed the first year. Within the structure of the ACO program, the first 3 years for all Pioneer ACOs, and there are 32 across the country, the first 3 years are really a guaranteed participation, and then those organizations that are able to demonstrate cost savings and quality outcomes are given the opportunity to participate going on in years 4 and 5 with a relatively novel payment structure from Medicare, which will include a little bit of a prospective payment as well as a partially reduced fee-for-service payment. And that is then a total of a 5-year program, if I remember correctly, before it's then reevaluated. The program goals are really what Dr. Billy's already spoken to. It's the triple aim, right? It's the cost, quality, and patient experience that we're trying to measure to. Our target savings is a 2% savings over the comparison group. So the comparison group will have some cost growth over time, and it's our goal to be less than that by at least 2%. The other thing that I was asked to comment on was how we communicate across health systems within the ACO. So we have a leadership structure, including a steering committee and a communications committee, and those are members of each of the various organizations come to those and sort of disseminate the information throughout their organizations as needed. We also have regular conference calls with Medicare, including representation from both organizations in order to have our issues heard from them and as well as to get feedback from the organization for how the program is evolving. And then the last thing I was asked to touch on is the overlap with the WHI and the work that you all are doing. And I have to admit, my role in the Population Health Office is relatively new. I've been there for a grand total of about 10 weeks, so forgive me that I don't have a great depth of knowledge in what the Washtenaw Health Initiative does. But as I understand it, this group is really working on the under- and uninsured patient population and their access to care and some of the unique issues that they face. And so to that end, the ACO project doesn't specifically overlap with a lot of work that WHI is doing, except that, as Dr. Billy mentioned, we really, and my perspective on how I lead this office at the University of Michigan, is really payer blind, or payer neutral is another way to describe that. So we're working on reforming our system and the way that we deliver care across our organization. And I'm not particularly focused on Medicare patients. I'm not particularly focused on Blue Cross patients. I'm interested in reforming the way in which we approach patient care, and as such, it will impact the patients that the WHI is working on. But it's a tangential association, I suppose. You could look at it that way. And I think that is what I have to say. So.
Hi. Sorry, thank you. Thank you for having me here to talk about my VA. I'm a veteran of the United States Navy, so this is my healthcare system. The VA serves 5 to 6 million veterans in 152 medical centers located across the country, the Philippines, Guam, United Virgin Islands, Samoa, and Puerto Rico, where I know we'd like to be right now. There's approximately 120 or 80% of these medical centers are affiliated with medical and nursing schools, and we are divided into 21 veteran integrated service networks called VISNs. Ann Arbor is located in VISN 11. We encompass the Lower Peninsula, the northwestern tip of Ohio, all of Indiana, and the midsection of Illinois. I don't know how we got all of that, because if you're in the UP, your main medical center is Milwaukee. So how that figured out, it wasn't left up to me. But that's who we got. In Ann Arbor, we service 37,000 veterans in primary care. We have 3 community-based outpatient clinics associated with our medical center. One is in Flint, one is in Jackson, and one is in Toledo. That's how we got that little section of Ohio. We also service another 20,000 veterans in our specialty clinics. We provide specialty care, mental health. We have an emergency department that saw over 20,000 veterans last year, servicing through it. We are all connected by a wonderful electronic medical record. So our many patients who go south for the winter are able to have their records. The providers in Florida can see, oh, he's on whatever medications. We share patients who are getting Coumadin morphine therapy so that there isn't a drop in their care. We let them know, okay, he's coming, he needs to be seen, he has enough medication. Then when the patient is coming back to us, they call us and say, okay, he's on his way back. So that continuity of care is maintained. We have our patient-centered medical home in the VA, because we have to be a little different. It's a patient-aligned care team, or PACT. We have the health delivery model, which focuses on early detection and prevention of disease. We have our mental health services are integrated into our primary care clinics. So if our primary care provider is seeing a patient who's having a mental health issue, they can be walked over with a warm handoff to the provider right there in the clinic and not having to go to another part of the hospital. We also have mental health embedded in all of our CBACs, so the health services are very seamless. In our PAC teamlets, we have our provider, we have an RN case manager, an LPN, and a clerk, and they have a panel of 1,000 to 1,200 patients that they manage together as their teamlet and see and get to know, provide care for. We have extended hours, so we see patients on Saturdays, 2 evening clinics. We have a navigator tool program that we use. A case manager will call the patients and utilize this tool to find out what programs will be beneficial for the patient. Does he prefer one-on-one case management? Does he prefer a class? Does he prefer using at home, be connected, using a telephone monitor, computer monitor? We have a very active homeless social work program, identifying patients in the community who are homeless or about to become at risk for being homeless, and targeting and making sure that they are connected with the appropriate resources. We're also very active with the Veterans Justice Outreach Program. We have a growing telemedicine virtual care program. We have a My Healthy Vet, which is a program. It's a computer program. You log in and you're able to view your medical record. You can see your lab results, see if you have an appointment come up, renew your medications. Our director likes to talk to his provider whenever he wants, so we have to make sure we have that up and going for his utilization. We do visits with patients in the community. If they're at the CBAC and the specialist is at the main hospital. So we're able to connect via telemedicine that way. How we are interested in working with WHI is only 30% of our eligible veterans use the VA, so we would like to have them be aware that we are there for them, and we only treat the veteran. We do not treat the family member, and so we need to be aware of what resources are there for them and partner with you so that we can care for the entire family. Thank you.
Great. Lori.
Okay, so IT, if only we had what the VA system had. That's what we're trying to emulate. So I liken the IT nomogram to the triple aim of getting the right information at the right time to the right people who need to use it. So that's what many of us around the table are trying to do. There are large federal government initiatives related to IT that you're all familiar with. The federal government's help and funding to get electronic medical records into all of the provider offices. That's a good step. It's not going to help us take us to the promised land. And I like to quote the CEO of Kaiser, who has said, you're taking electronic charts and just making electronic silos. No longer do we have paper charts, you have computers not talking to each other. And if any of us have been a patient and gone into the institution and you say to yourself, how many more times do I have to give the same information at the same time? And as my dad says, is it in that computer that I just gave you the last time I was here? So we are trying to look at the various federal initiatives that are out there, and here in the state of Michigan we have 6 different health information exchanges that are currently active in the state that is to help us get information to the right people at the right time. That, to quote Jack, would be a little too much of a good thing. So there are 2 large health information exchanges that are probably more pertinent to the Washtenaw County area, and that is the Great Lakes Health Information Exchange, otherwise known as GLEE, which the University of Michigan is part of and has sent their data in. Then there's the Michigan Health Connect, MHC, which Trinity Health and St. Joe's is a very active partner in that. And that's great, except if you're a doctor, split right in the middle, and you need information from both systems, it's been a little bit of a challenge to figure out what to do. So how this relates to activity here, we have 3 organizations, University of Michigan, IHA, and HVPA, with the 2 participating hospitals, through Blue Cross Blue Shield of Michigan and the Organized Systems of Care, giving us a challenge of how we can better communicate as a community of our patients. In that resides the uninsured, Washtenaw Health Plan. And most of us have been working on tools to help us manage patients using IT tools. The most common probably being a registry that you may have heard about, a patient registry, to know who our patients are, how we can outreach to them. Everybody has their own systems, so we're trying to, as I like to say, do the poor man or dumb blonde way of trying to figure out how to connect these all together. And we've got some bright folks at the table, and I think over this next year, through the organized systems of care and the pioneer of trying to identify our community of patients, we'll know who they are, and each of our systems are going to try to put those lists together, try to identify those patients who are most at risk on multiple medications, been seen in the ER, and we will piece this together because there's this other thing out there called HIPAA, and dare I say the compliance officers of institutions, that we can come out of a room and say we'd like to do all this, and there's a lot of other committees and organizations that have to go through to sign off to make sure that we're not violating any information. And more importantly, to keeping the patient in the middle of that. And I think if we can do a better job of educating our patients to get that information out to their providers so that they're more comfortable in sharing that information and feeling comfortable signing off on those forms, that will help. So as part of our organized system of care initiative, some of the funding that has been given to the organizations by Blue Cross Blue Shield of Michigan and other payers, the MyPick Project, and the various health plans, our three groups are pooling some of those resources to try to do this together versus apart. These are expensive systems. Those of you sitting here putting in electronic medical records at the hospital, I mean, we're talking multi-millions of dollars. You can only make that decision once and then need to work with it. Some things that have happened this year, right now, the University of Michigan and St. Joe's ERs, if you happen to show up in one of those ERs, they now actually have view rights into each other's electronic medical record to at least to begin to look at medications and services. It's my opinion that that will go a long way to help reduce cost, because a lot of the stuff that we do is to repeat test because we either can't find the results, it's easier, we need them now, we can't wait 24 hours to get those back. And there's some safety issues there. You don't want to be CT'd again if you don't need to. There's some radiation exposure to that. So I think that would be the third arm of the triple aim in reducing cost. But it is a Herculean effort to take on.
Yeah, I can maybe a comment on the organized system of care. We can test the hang radio back. So Mary Durfee is the medical director of Integrated Health Associates, was supposed to be on the panel, wasn't able to make it. But the organized system of care is yet another name for population health, and that mostly is focused on Blue Cross patients. And so everywhere else around the state, they're taking what are called patient-centered medical homes, a home who knows you and who is keeping track of you and reaching out and trying to make sure you get what you need, taking responsibility for you for quality, cost, and the like. So those are the patient-centered medical homes we've heard about. Well, organized system of care is one step above that. Tim called it an ACO, or accountable care organization, but these are a way of not just having the core, the primary care, the little network here, but also having specialists around that, and then having hospitals and ambulatory surgical facilities, and then having community providers, home care, hospice, skilled nursing facilities, safety net, WCHO, WHP, and the like, all those other wraparound services. So those, so Blue Cross calls that an organized system of care. Medicare calls that an accountable care organization. And so, but we had an opportunity in our county to have an organized system of care. Every other county, the competing physician organizations, like Huron Valley Physicians and the university or Integrated Health Associates, they would form different ones. We'd form 3 different ones of these, and then we'd be fighting with each other. So we decided in this county to do something different. It's not being done anywhere else in the state, and I don't even know of it being done in the country, which is to say we're going to have one organized system of care here. So we've decided, that's what I was saying before about this being all patient, all payer. But instead of Blue Cross contracting with each of us entirely separately, we put together an application and sent it in, and Blue Cross agreed to try this experiment with us, whether we can sit down together and figure out how to improve things like people who are being seen in the emergency room for something that their primary care physician could have treated, or people with heart failure getting readmitted to the hospital. It turns out that about 20% of the patients who are admitted from Integrated Health Associates, even though they are closely affiliated with Trinity and St. Joe's, but about 20% of their admissions are at our facility, and 20% more are outside the county altogether. And so how do we create a comprehensive view of these people so it's so the people who do split their care aren't fragmented? So that's the organized system of care, and we're very grateful that Blue Cross is willing to run this experiment with us in the county, so that instead of having 3 different organizations do it, we're doing it together. And we're trying to take it one better, which is to say, instead of knowing that we only, that patient has either Medicare, Medicaid, Blue Cross, or Blue Care Network, or that patient has Medicare, or that patient has Blue Cross. Instead, we'll try and have one model regardless of what that patient's insurance would be. And that's where you all come in, because why should it stop at the people who have insurance? It should also extend down to the people who don't, but hopefully will before too long, to be able to bring them in. So I just wanted to make a couple of other things. May I, Madam Panel runner. So I was lucky enough to be at Stanford a couple weeks ago at a health policy conference run by the White House Office of Technology, and they were talking about all this population health stuff, and they were saying, is anybody looking at integrating it around the entire community? And I was able to raise my hand, not because of what we did with the organized system of care, which is the sort of provider side of this and the insured side of this, but because of what you were doing. And to say that, yep, we're trying to cover it from the insured people's perspective to integrate the system better, and we're collaborating with the people who are trying to cover it from the uninsured and underserved and difficult access and complex social issues. So I hope that what I predicted will be able to come true here as well. And I did want to mention one other thing. Brent, are you over there? So Brent Williams and I think Ellen Rabinowitz, if I'm not mistaken, are working on a care coordination model. So Tim, when you said you're not sure how much interface there is, actually there are some early experiments with a few of you trying to figure out what does care coordination look like across the county, rather than doing this piecemeal where MyPICT is paying for care navigators that are in the offices. The U of M has some that are centrally located, and HVPA has theirs, trying to understand that whole distribution and to rationalize it a little bit so that we can get the needs of the clients met, rather than doing these individual payer assessments. And the last thing I will say was, so what's wrong with just letting everything happen the way it's been happening so far? Why not just have MyPICT, and then for Medicare we'll have that, and for Blue Cross we'll have this? What's the problem? So the problem is all of these have different attribution models. By one attribution model, this patient may be in my primary care home for one of these plans, and in Diane's for another. So we're even not sure which patient is in which. They also have different methods of measuring performance, different quality goals. They have different standards for each of those quality. They have different reward systems, where some of them are paying for care coordinators in the practices. Others, like the shared savings model that Tim talked about, Medicare gives us no money up front, but they're willing to split the savings with us if we save some money. So we have all these different conflicting messages coming down, and we're trying to organize the delivery system, and we're getting all these different conflicting messages. So that's why I hope that we'll be able to just develop one model consistently across the county.
And it's a great effort, and it's not that it's without will or good intent that a common attribution model and a common way to approach this across all patients is not existent in the state right now. It is that we have some work to do in documenting and establishing the value to the entire community, so that that this can happen. But it's the perfect. It's not the long-term vision. It's the vision we have to reach in the pretty immediate future, but it's an intermediate step.
We're each under our own hook, if you will. So my pick is under a hook to show budget neutrality to Medicare within a short period of time.
And patient improvement.
And improvement. And the Medicare demonstration called the Pioneer is under the hook that if they don't save a certain amount of money, cross the threshold, Medicare gives us no money, and then all the money that we've spent, we're out. Well, you know, at least patients got better care, but each of these has its own, hook. Now it's their turn.
Like I said before, the whole point of this is for you to get all your questions asked. So I'm sure you have plenty. So I'm going to repeat your questions so we can get it recorded for those of us who have to miss. So if you do have a question, I can call on you, and then you can direct it at one person or just in general, and we'll see who wants to take the question. Bob Laverty, what's your question?
Jack, I was pleased to hear you say about there's all this activity going on, which you folks represent, which are the big gunners, the health systems, the insurance company, and your focus is on those folks who, you know, the insured population, if you will. But I was pleased to hear you say eventually that orbit needs to come together with the orbit we're working on.
Right.
What is, and you're a bridging person in all of this.
Thank you.
What is your sense of the timing and the process of how that will come together in the future?
So I'll give you one person's perspective, that's all. You reach a point when you're trying to provide services to a population where it gets so complicated to figure out who's eligible for what service that it's actually just simpler and even cheaper to be able to just say we're going to provide this for everybody than to start saying, well, this person's eligible for this outreach or that outreach. And in my opinion, we've already passed that point, though I'm sure folks don't agree with me. Because, you know, imagine, okay, the person's 64 and they're discharged from the hospital, so they don't have Medicare, so we don't have a care navigator calling them to make sure that they reached home safely and they understand their complex medications. You know, it doesn't make sense to not do that for a 64, but to do it for a 65 because they now have Medicare. You know, you reach a point where trying to navigate that maze is more trouble than it's worth. And if there were only a very small percentage of the population for which this was happening, I think we'd be farther away from that. But I think we're way past that tipping point, in my opinion. If you look at the actual population of the county, more people are in one of these population management programs than not. I think maybe by a factor of 2 or 3. So, but there's still this temptation to say, well, I'm only getting paid for this person to do that, and I'm only going to recover shared savings if I save this Medicare admission. So I think, I think the theoretically we're there, but practically I think that'll be more retail. I don't know if others, yeah, please.
We're actually there on one large part right now. Between the 3 organizations, U of M, IHA, and HVPA, we're 6 years into the PJIP program where we've been building patient registries, and we take the eyepiece of this. When you go to the doctor and you reg and they take all your information down that goes into what's called the practice management system, we have taken that data from our practice management system, so any patient that's in there, the uninsured who have come in, their data is in there, and we're already putting that in our registry. So reminders come up to say when Susie Jones needs a mammogram. And to Jack's point, it doesn't matter if Susie Jones has BCN, Medicare, no insurance. So I would say here in this county, you've got a good 4 years of population preventative health alerts being triggered among our various systems.
So Jack,
Yeah.
Many people do not know what PJIP is. Could you define?
Well, and so I want to give credit to Tom Simmer from Blue Cross, because from the beginning of this program, just exactly as Lori described, the goal was to develop the systems for all the people that you cared for in that practice.
you want to give the acronym?
So PJIP, the Physician Group Incentive Program, is what started as a few $1 million program and is now over $100 million a year that's spent from Blue Cross, essentially from employers, because that's where Blue Cross gets its money, and subscribers, but it's invested in building the capabilities to take better care of patients to meet this triple aim. So it's used to create registries, which means which of my patients has diabetes, which of my patients has asthma, and then how am I doing on those patients, to measure my performance, to feed it back to me, and then to set up systems where, you know, I've told the story before, but I went from not knowing who my diabetics were to knowing who they were, but not how I did, to knowing who they were and how I did, but not on the specific patient, to knowing how I was doing on the specific patient, but not the day I was seeing them, to knowing the day I was seeing them, to having the problem solved before I actually saw them, because we set up a process in my office. And that was all funded through the Physician Group Incentive Program. So Blue Cross has been all payer, all patient in its philosophy from the beginning, but that's only while that's extremely helpful, it's just not sufficient to really turn the whole juggernaut, and that's why we're trying to also put things like the Michigan Primary Care Transformation and the Pioneer ACO and another ACO that we're involved in for Medicare patients to try and incorporate them in. And even those populations don't deal with the uninsured. We don't get payer information from the uninsured. So we can't use claims information to see if my uninsured patient got a mammogram at St. Joe's or Barbara Threet's office. So, you know, because there is no payment for that. So there's challenges in trying to make that come true. I don't know, Tom, do you have any comments on that?
I appreciate the recognition that you gave, and other than that, I think you hit the nail on the head. You described it well.
Are there any other questions for the panel? Yes, Marcy.
It really isn't a question, it's just a comment. And that this is so cool that we are sort of engaging in this practice and we're doing it collaboratively together. And I think it's just pushing us way further into the future than we can ever imagine. It's cool.
Huda, go ahead.
Actually, I was kind of thinking the same thing. I mean, we're so lucky to have so many resources here in Washtenaw County. But, you know, the Primary Care Transformation Project, the ACOs, the Organized Systems of Care, the VA, they're national. Or, I mean, they're statewide, maybe national. So I guess I'm sort of wondering, can you tell us a little bit about what's going on in the non-Washtenaw areas, and how is that succeeding?
Go ahead, and then I want to.
Yeah, can share a few things. It's fascinating to work. I mean, we have we have practices in the Upper Peninsula. We have practices. I know too much of Michigan geography. There can never be too much of Michigan geography. But I've been to Muskegon plenty of times, and I've never been there. But anyway, long story short, we find that there are such interesting things and different capabilities and centers of expertise within each of the regions. For example, in the Upper Peninsula, they are some of the smartest connectors of the medical neighborhood. The resource, how do you get the things that are always a little bit challenging? How do we get a social worker in here to work with us? How do we get a behavioral health specialist? And the nation doesn't have the answer to that, but in the Upper Peninsula, because of many geographic factors, they've had to think about this, and often it's a paper system, but they've got it. So it's so interesting, Huda, that there are different centers, there are different best practices in the different regions. I don't know that there are a lot of other regions. You are lucky to have yourselves in Washtenaw County and to have the leadership that exists in this room and beyond. So much has been enabled here, and so much that can be a role model for the rest of the state. But it delights us to find those pockets of great things that are happening in other regions that can be shared.
So one other thing, Marianne, I don't know can you talk about the spread of the WHI? Is there, that would be helpful, and then.
Just very quickly, in terms of the WHI, we are in the process of trying to work with Pontiac to expand this sort of concept in the Pontiac community. And our plan is to submit a grant to the Southeast Michigan Community Foundation. What's exciting about Pontiac, and of course very different from Washtenaw County, Pontiac is an extremely distressed community in Michigan, very high poverty rates. When I was in the Grant Home Administration, we called it a city of promise, which was a nice way of saying that they really have a lot of needs. So it's a great demonstration to see if we can take some of the learnings that we've had here and apply it in another community. They've got all the hospitals at the table in that community. There are 5 hospitals. They have all committed $20,000 per hospital for a WHI-like initiative in their community. And Senator Marlowe, who is the head of the Health Policy Committee in the State Senate, is chairing their effort. So they've come together, and we are trying to help other communities that are interested in doing this kind of work, where you bring like you guys, bring everyone together to really align and try to build on the resources each organization has individually to help serve this population. We're hoping that we can do this for other communities. So there'll be a task. We're doing it in partnership with the Greater Detroit Area Health Council, who will help facilitate them, and we will give them a toolkit and help get them started.
So one of the other unique things in Michigan is that even small practices have access to these practice transformation resources. For one thing, because the Physician Group Incentive Plan from Blue Cross is generous in supporting physician organizations, but the State Medical Society started up a few years back something called the Medical Advantage Group that goes around to small community practices and helps them do what in our community the HVPA or the faculty group practice at the university or IHA would be able to do. And they include federally qualified health centers. So in most other markets, FQHCs are totally out of this game. They're not, they wouldn't have this discussion here. But in Michigan, because of Medical Advantage Group and Blue Cross's funding of that, they're able to help those organizations ramp up some of these patient-centered medical home capabilities.
I'll comment. We're running into that a little bit now with our three groups. I think the uniqueness of what you guys are doing, inventorying what's out there, I think there's a real danger in duplicating services, and we're beginning to see that even in our high-risk management patients. I mean, these patients are getting 1, 2, 3, 4, 5 phone calls because each of us are in our little, well, we got to, question and care manage this piece, and somebody needs this. So I think some of the work that Ellen and her team are doing of inventorying that, there's always the danger when you get that funding that you've got to use it, and thus that begets too many. And I know Tom and I have had this conversation early on in PGIP. Just because everybody could have an RN that doesn't mean everybody needs an RN. So it's balancing, the need versus the availability.
Tim, the Pioneer ACO is one of 32 you said across the country?
Yeah, so from a national perspective on ACOs, the Pioneer program is a closed program. There are only 32 in the beginning. There will only be 32 throughout that program. But on a broader scale of what Medicare is doing with ACOs, there's a whole spectrum of shared savings programs. And in the first year, I want to say there were 30 or 40 of the shared savings ACOs. And this year there were an additional 140, so roughly 200 total. It's a growing movement across the country. The University of Michigan has a second that's called the POM ACO, which is part of the shared savings model and incorporates roughly 1,500 medical providers across the state. And there's also been a large interest in several groups that weren't initially part of it who are already asking if they can become involved with it as well. And I think that's a national trend. You're seeing a lot of providers organizing around this ACO movement so that they can begin to understand what it takes to work in a shared savings environment so that they can begin to build that infrastructure. We have the advantage of having been doing that for quite a while, and so we were able to move into that Pioneer project. But I think you're seeing that this idea of shared savings models for insurance coverage, it's not only within Blue Cross and the OSC movement, within Medicare, but it's gaining traction across the country, and you're seeing more and more providers trying to find a way that they can learn about that, and by participating in it.
And you're going to have to do it with economies of scale because the IT infrastructure is way too costly. And just thinking, if you think of what the VA's done, they were able to do it with one system, and from an economies of scale, I don't think there's been a study yet that has shown that that's not been a cost-effective model. Instead of each of us going and replicating that IT infrastructure, I think other physician organizations and groups will try to migrate into established ones because you won't be able to afford the cost to do the infrastructure for that.
So I promised that I wouldn't show my A3, but those of you who want to see it can come up afterwards because it has, all you need to see is what you can see from back there, which is the wiring diagram of all the different electronic records where Trinity has Cerner, the U of M has Epic and Eclipsys, and the HVPA docs have whatever they have, everything. And we use Cielo as a registry of who our diabetics and asthmatics are. And HVPA uses
We brew one.
their own grown one, and IHA has a different product. And so none of these things talk to each other. So trying to figure out who the county's diabetics and asthmatics are, it's great that we were encouraged to put all our patients in with diabetes and asthma, not just Blue Cross's patients, so we have that information and can reach out to them when they haven't been immunized and they don't have the retinal exam and the like. But it's still, we can't talk across each other, and that was why this experiment in Washtenaw County is so exciting, to try and do this once together, and Lori leads that group.
And going back to your question, Huda, the MIPCT is one of 8 or 9
We're one
sites?
of 8 total partner states.
But the other states have...
Some of the other states, I talked to Vermont this morning. Vermont has been in operation since 2008. So some of the other states have been doing this work, some of them from regulatory mandate, others in another way. But they have but that might not be what Jack was referencing.
Right.
But they're a hell of a lot smaller. Right.
So they're so much smaller that Michigan actually has more practices and patients in their demonstration than all the other states put together.
Minnesota is on our tails.
Yeah. So, Ron McDermott has...
Yes. I'm so sorry.
From the VA perspective, that we talked about in our inclusion in WHI, which I think is unique nationwide. We have been an accountable care organization long before the term came into fashion, and our mission is to honor America's veterans by providing exceptional health care which improves their health and well-being. And a lot of the themes you've heard here, we've been doing for a long time as an organization, and again, WHI reached out to VA to include us as a community partner. I'm in a role right now where I'm actually managing that whole part of the country that Jenny talked about for VA, and serving on a number of national boards. And there's nobody that is doing this in VA. And I think to not pay attention to a system that cares for 7 million citizens in this country and does it in a fairly comprehensive way is a shame. And that this community has changed that by including VA is very commendable, and I think it's really a tribute to WHI and to the Ann Arbor community.
Well, we're glad to have you. Bill, you had a question? Yes.
Well, at IHA, we believe the best care is delivered when there's an established relationship between the patient and a provider, typically in a patient-centered medical home and neighborhood. The term attribution was identified a number of times, and that's a way of saying, after the fact, we'll tell you who your patients were. Very difficult to care for patients after the fact. So the question, this is obviously a much more challenging population when we look at the underserved. And so the question is, how does the agencies in this room help on the front end enable us to match up patients with their provider teams? And secondly, how do the agencies in this room link up with the medical community so that the resources you have here are better connected, and as a team we're providing the care going forward?
I'd like to take a stab at that.
Just as some of you probably know, what's happened in Muskegon for many years. I think it's called Access Health, but I might have the name wrong. So that's a program to try and get primary care access for underserved indigent patients, don't qualify for Medicaid. And but one of the things that they do is Vondi, I think her name is, I don't remember, walks around to doctor's office and she says, okay, Dr. Rabinowitz, how many can I sign you up for? And I'll promise you that if you're the only doctor, that you won't be the only doctor who's seeing the uninsured in this town, I'll sign you up for 10 or 20. And so they do a very conscious leveling of the demand so that it's not like the one dentist or one primary care office or 10 get deluged. So I think that's an opportunity for coordination, especially in anticipation when the expansion goes through, that there'll be a lot of people seeking primary care. Instead of just letting it all happen, maybe we can help encourage people to level across the resources. So that, I think, who would do that, I don't know. This group is the best positioned group to try and discuss that and come up with a model that meets the needs of the patient. It's not that we're going to tell them where to go, but that doesn't just let it all happen by chance.
Well, there's some simplicity that some of my questions I'm usually always asking. It's kind of simple as list. And I think to Bill's point, some of your services sometimes tend to get siloed. We either don't know about them or they're not put in an easy way. Dr. Penrose is here when she worked at the Packard. Groups like that have to have those lists and those resources readily at the fingertips. The dentist program you're just doing. I took a page of notes and thought, I don't have that list. I have 600 doctors I could get that name out. I laugh because one of the early PGIP initiatives we were asked to do was linkages to the community. That was an initiative we could all sign up on. And I was like, why would we do this? And what happened? You had 40 POs start putting binders together of the community-based services. We need to notch that up either into the business community, people that could help collate that. So the same binder that HVPA is looking at, that the VA is looking at, that IHA is looking at, so we're not all replicating that.
We created on our intranet website for any staff member in our medical center of a patient who's diabetic. I can type in diabetes and it tells me what classes are available, when the classes are, all of the brochures, everything, so that, and everything's standardized and updated so that I know that if he's being seen, if he being discharged from my clinic and now he's going to receive care in Flint, the Flint nurse knows exactly what resources I gave. She's giving the same ones, the same teaching. The classes that we have in Ann Arbor are also the same classes, the same content at all of our CBOCs at all our sites. So it's all fluid. And we started calling it our little wiki site. And it has just grown.
I want to add an anecdote to this. I attended one of the MIPCT trainings for their care managers across the state, and it was in Southeast Michigan. And Diane started the day by asking questions, practices in this room, what things are you good at? Let's go through a list. And they went through lists of relationships with the local hospitals, relationships with your physician group. And she asked, what are your relationships with local community resources? If they're very good, raise your hand. And there was no hands. There were just so few hands that were raised in that room. The care managers were like, we don't really know what is available. So I think that's exactly what your question is, and that's a question that's been in Washtenaw County for a long time. Does anybody want to add to that?
So just to add a couple things. So in terms of the uninsured, and Jack, you were referencing the Access Health model in Muskegon. So through the Washtenaw Health Plan, through the generosity of our hospital partners, we actually have 37, and including IHA sites, there are 37 primary care sites through U of M, through St. Joe's, through IHA, and of course our safety net partners at Packard and the Corner that provide the medical home for low-income Medicaid and WHP members. So we have a strong foundation to really build on. And I just thinking about, and you mentioned this also, Jack, how we begin to coordinate it all. I really love your analogy of putting the two orbits together. So through the WHI, we're launching this care management network that is focused on the low-income, uninsured Medicaid population that is going to attempt to do exactly what you're talking about with the payer population. Mm-hmm. So what we need to do to bring that together, I mean, there's work to be done, but there's definitely a lot going on that we can build on.
Right, and I think one of the things that the project we're doing with Blue Cross and Blue Cross Complete is trying to do is to try to pull patients who enroll in Medicaid in to see their primary care doctors quickly, because we were concerned that they might enroll in Medicaid but actually never get that kind of preventive screening assessment. So I think we could also align what you're asking for with that primary care group and with the Blue Cross Complete project to try and identify early on who is the attributed patient in that population.
Yeah, I just wanted to mention in part to answer your question. I work with the health information exchanges that Lori referenced, and when the hospitals are sending out who's been admitted, transferred, or discharged, they want to send that information out. And when we were talking about what's the source of truth as to whose patient that is, so that we can share the information legitimately, the source of truth appears to be the practice, not the health plan's attribution model. So each practice will have the responsibility in the sort of era of information exchange to have a clean, updated list of all of the people who have a care relationship with that practice, and then offer that up so that when the hospital list of people who are admitted hits against a patient list, they now know who to send that information to based on who has an active care relationship, which is the part of the business associates agreement that authorizes all of this. So I think it's one of the new burdens or roles that each practice will possess, is to keep a current list of people with whom they have a care relationship, and that list should include people of any coverage or non-coverage, but if they have a care relationship. And so that's the model that's being built throughout the state as we're working on these admission, discharge, and transfer information exchanges.
Last question, Ruth.
Lori, I'm wondering if you could talk a little bit about, besides the willingness to work together, what other sort of roadblocks existed, say, to getting the U of M and St. Joe's ER's view capabilities? For these IT things, there's technology barriers and there's the willingness to work, but what else is there?
I don't know which way to classify it. I'll put it under, I guess I'll say, workflow. So giving people access to tools, but if you haven't done the rework to build it in their workflow, and just because somebody says, geez, you can open this up in this view box, but then you have 12 different clicks to try to tie it all in, that's not real helpful. So I think between both of the institutions, ironically, when you think of electronic medical records in the hospital, Tim should be speaking this. I know at St. Joe's, they have a different version of the electronic medical record. It's called FirstNet. It's kind of a specialized EMR. And then there's the hospital EMR. So just getting the right information into those systems, and who's to look at it. Is it the doc? Do you have front staff? And Tim, you're probably better to, you live that every day.
So the dangerous thing that I'm going to say right now is that I didn't know that I could get into St. Joe's records. So there's your first barrier.
Well, you know what? And Rob's gone now, so I can't. I know that.
There.
I think residents could, on some computers, very few computers.
So there has always been, so the University of Michigan residents, it's the University of Michigan Emergency Department Residency is a shared program with St. Joe's. And so the residents have always been able to access both systems. Even St. Joe's has gone through 2 or 3 different EMRs in the course of the last 8 years.
Right.
And there's always been some backdoor way for the residents to do that.
Well, we were told that, I mean, in our last OSC meeting, that it was open and live. Like I said, Rob's gone now, but I think
that speaks to the barriers.
Right, yeah.
So one is disseminating the information to the people that have
Well, we'll get the answer. Sorry.
The other is that people have to be trained on how.
Yes,
so Epic is incredibly complicated. For me, I work in Epic every day. For me to get information out of it to take care of patients is a Herculean effort. For me to learn NextGen or Cerner or whichever the system is another effort that requires time and energy. And in truth, if I've got 3 hours to take care of a person, I can't really devote half of that or even 10% of that to digging through somebody else's IT system to get a piece of information. Especially as an emergency physician, when I've got people coming through the front door all the time, I got to go see the next patient. Right? So it's the work. You've got to build it into workflow in such a way that it's seamless and easy, and the information is there and ready and available. So.
And EMRs right now are not doing that. I mean, for those of us that work, they have lots of stuff in it, but you've got to take it up and summarize it in the quick view way that, you would like a fighter pilot analogy. I mean, lots of information, but you need what in front of you for your dashboard to land.
Well, thank you, panelists. We really appreciate it.